Golden notes: alcoholic liver disease. In fact, alcohol is one of the most common causes of chronic liver disease worldwide, with consumption continuing to increase in many countries. Patients with alcoholic liver disease, ALD, may also have risk factors for other liver disease, like coexisting non-alcoholic fatty liver disease or chronic viral hepatitis infection. And these may interact to increase disease severity. In the UK, a unit of alcohol contains 8 grams of ethanol. An upper threshold of 14 units per week in women and 21 units per week in men is generally considered safe. Recently, however, Public Health England advice has adopted a more conservative threshold of 14 units per week for both men and women. The risk threshold for developing alcoholic liver disease is variable but begins at 30 grams per day of ethanol. There's no clear linear relationship between dose and liver damage. However, for many, consumption of more than 80 grams per day for more than 5 years is required to confer significant risk of advanced liver disease. The average alcohol consumption of a man with cirrhosis is 160 grams per day for over 8 years. So the government guidelines suggest that women should not have more than 2 to 3 units per day and men should not have more than 3 to 4 units per day. Alcoholic liver disease includes fatty liver, alcoholic hepatitis, and cirrhosis. The fatty liver, hepatic steatosis, accumulation of fat within the hepatocytes, asymptomatic and detected incidentally. Elevated transaminases and background of alcoholism are clues to the diagnosis. Macrovesicular fatty changes and microvesicular fatty changes are not found in hepatic steatosis. An ultrasound demonstrates hyperechogenicity and a bright liver. This is reversible with abstention from alcohol. So the alcoholic fatty liver disease, the AFLD, usually present with elevated transaminases in the absence of hepatomegaly. It has a good prognosis, and steatosis usually disappears after 3 months of abstinence. Now, the alcoholic hepatitis presents as acute right upper quadrant pain, tender hepatosplenomegaly, jaundice, fever, frequently occurs on a background of cirrhosis, marked the range of liver function tests. Liver function tests typically show an AST elevated greater than the ALT, with at least a 2:1 ratio. Remember that complications of portal hypertension may also be present in alcoholic hepatitis. It has significantly worse prognosis than AFLD. About 1/3 of patients die in the acute episode, particularly those with hepatic encephalopathy or a prolonged PT. Cirrhosis often coexists. If not present, it is the likely outcome if drinking continues. Patients with acute alcoholic hepatitis often deteriorate during the first 1 to 3 weeks in hospital, even if they abstain. It may take up to 6 months for jaundice to resolve. In patients presenting with jaundice who subsequently abstain, the 3 and 5 year survival is 70%. In contrast, those who continue to drink have 3 and 5 year survival rates of 60 and 34% respectively. Remember very well that AST to ALT ratio can be useful in diagnosing alcoholic liver disease because more than 2/3 of patients will have a ratio greater than 2. Transaminases are typically only slightly elevated, rarely over 300 and virtually never over 500. The alkaline phosphatase may well be significantly elevated, giving the liver profile and obstructive appearance. High AGA levels are seen in alcoholic liver disease. At a microscopic level, there is inflammation of the liver. In liver cirrhosis, the hepatocytes are damaged so much that they are replaced by scar tissue, which is permanent. The cardiomyopathy of alcoholism is a dilated or congestive form. Alcoholic hepatitis and cirrhosis may coexist. Alcoholic hepatitis and cirrhosis may lead to encephalopathy, portal vein hypertension, and hepatorenal syndrome. Increased risk of infections, and they are usually malnourished. Treatment involves good nutrition and abstinence from alcohol. There is no specific therapy for alcohol-related hepatitis and cirrhosis. Treat the complications, which include ascites, high doses of diuretics, spontaneous bacterial peritonitis, hepatic encephalopathy, and esophageal varices. Chronic alcohol abuse is typically associated with increased carbohydrate-deficient transferrin (CDT). They may ask us which feature would suggest a diagnosis of hepatic steatosis rather than non-alcoholic fatty liver disease. It should be reversible hepatic damage after discontinuing alcohol consumption. You should remember that Dupuytren contracture parotitis may be associated with alcoholic liver disease. Now, the common abnormalities in chronic alcohol dependence, macrocytosis, elevated gamma GT. This is due to enzyme induction, but does not necessarily indicate that there is liver damage. Hypertriglyceridemia can contribute to pancreatitis, hyperuricemia, but hypoglycemia can contribute to seizures and coma. Hypomagnesemia, hypogonadism, thiamine deficiency, increased carbohydrate deficient transferrin, considered a marker of chronic abuse and sometimes checked to ensure abstinence. For example, while awaiting liver transplantation, iron levels are variable in alcohol dependence. Hepatitis causes increased serum iron, while poor diet can result in iron deficiency. Ferritin can be elevated in the acute phase response but reduced in advanced liver disease due to possible reduced synthesis rate. Hyponatremia and hypokalemia are often seen in established liver disease. ALT is elevated in liver disease and hepatocellular damage. AST is elevated but can also be increased in cardiac or muscular damage. Now, AST to ALT ratio can be elevated due to the mitochondrial effects of alcohol, causing a disproportionate increase in AST. However, this is not specific. Remember that the macrocytosis in the absence of anemia suggests and support a history of alcohol misuse. Raised gamma GT is not specific for alcohol misuse and may be also elevated in the presence of other conditions, including non-alcoholic fatty liver disease. The level may therefore not return to normal with abstinence if chronic liver disease is present, and gamma GT should not be relied on as an indicator of ongoing alcohol consumption. The presence of jaundice may suggest alcoholic hepatitis. Determining the extent of liver damage often requires a liver biopsy. In alcoholic hepatitis, PT and bilirubin are used to calculate a discriminant function, the DF, also known as the Madray score, which enables the clinician to assess prognosis. We have also the alcoholic cirrhosis, which often presents with a serious complications such as variceal hemorrhage or ascites, and only half of such patients will survive for 5 years from presentation. However, most who survive the initial illness and who become abstinent will survive beyond 5 years. The management will be cessation of alcohol consumption, which is the single most important treatment and prognostic factor. Also, good nutrition is very important, and enteral feeding via fine-bore nasogastric tube may be needed in severely ill patients. Roc Therapy. In fact, the optimum treatment of severe alcoholic hepatitis has been debated for some time. Treatment with prednisolone 40 mg daily for 28 days led to a modest reduction in short-term mortality. But neither glucocorticoids nor pentoxifylline improved survival at 90 days or 1 year. However, sepsis is the main side effect of glucocorticoids, and existing sepsis and varicose hemorrhage are the main contraindications to their use. If the bilirubin has not fallen 7 days after starting glucocorticoids, the drugs are unlikely to reduce mortality and should be stopped. This was provided by the SSSM Study Smart series for Mrcp, your easy way to easy pass. Remember that the sources of the Golden Notes are Davidson, Oxford Handbook series, and Essential Revision Notes for Mrcp, and Notes and Notes. Don't forget to follow us on Facebook, Telegram, and YouTube channel. Thank you very much.